All right. Welcome back, everybody, to this edition.
Which
of the MedTech
edition?
Jam session.
How many now, Mike?
I don't know. I think this is episode, we're going to call it episode 10.
Cool.
This is the MedTech Jam session with Chris and Mike D, and we're so happy that you've taken a few minutes to hang out with us. Our podcast is really designed for anyone who is interested in the medical technology space. We are speaking with founders, with builders, with disruptors to hear what they're building, to learn from them, and to experience through them the agony of defeat and the thrill of victory, sometimes in the same day. The struggle is real, and I think I've said that before as well. I'm super excited for our guest today. We're going to throw a bit of a change up. Our past several guests have been leaders of med tech companies, orthopedic companies, spine, sports, and we have a lot more to come. So you're going to want to subscribe to the MedTech Jam session. Go ahead and download this and stay up to date with what we're doing. But we're gonna move in a little different direction today and talk about something that I find super fascinating, which is remote monitoring and virtual care. And I think we were on the way towards this prior to the pandemic. I think the pandemic accelerated it greatly, and that may be one of the positives, if you can say that came out of what we learned from the pandemic. And so the idea of telemedicine, remote patient monitoring. In fact, we'll have to decide, Chris, if we want to include this in the podcast or not. But just this weekend, have you used the Cologuard? Have you ever seen that? You know what that is?
Yes, I have seen that.
Have you tried it?
No.
So my family has a history of colon cancer. So Cologuard sent me the box, and you provide a sample. Let's just leave it at that. And then you ship it to UPS. I felt bad about like bringing my sample to the UPS store. Here you go.
Here's
Don't
the contraband. Ask. It's the contraband.
But I find that to be a really creative approach to care, right? It's remote patient care in this case. And it saved me from having to have a doctor's appointment. And I'm going to find out in a few weeks if I need to go have a doctor's appointment with a GI specialist. It's a great screening tool. And so these types of innovations are really going to change the way healthcare is delivered.
Absolutely.
And today I'm super excited to have an old friend, a superstar who is building a really interesting virtual care platform and remote monitoring platform. And so I want to welcome to the stage our good friend, Scott Laster. Scott.
Hey, everybody. How are you? Thank you so much for having me.
Great to see you, Scott. I love those guitars in the background.
Absolutely.
It's the jam session. I thought I'd bring them out for Chris and Mike D. Make sure that we had a proper jam session going on.
Are you going to play a little bit, maybe? Maybe play a little bit?
If anybody wants their ears to bleed, I could definitely play some. And not in a good way. Oh, it's good to see your faces.
Cool looking instruments.
Yep.
All right, Scott. So thanks for hanging out with us. Thanks for jamming with us. It's great to see you personally. We've known each other for a long time. Used to work together back in the day. And I've always loved your energy, your vision, your passion. Tell us why in the world you left the world of corporate America really before remote monitoring was a thing to build MiCare Path. What were you thinking?
I love this question. And thank you both again for allowing us to be on the show. I'm very excited for this. The thing that we saw at the time, and I say we loosely because there were three co-founders as a part of the business, we saw a great vantage from the corporate angle. We saw a changing market, and I was blessed to be a part of a couple of different acquisitions, and they started shifting away from just pure metal and plastic towards an element of your show, which is enabling technologies, which includes still hardware and digital elements, but also virtual care and those types of things. So I was a part of that progression, an actual implant. Then it went to a robotics company. Then it went to a pure digital solution that I was involved in. And so seeing that progression and seeing how a medical device company thinks about the market and needing to stay ahead of some of the trends got my mind thinking about where the market was heading and what it needed from the professional side of things. And then the personal side of things was the other element that just collided with my professional life. And my story specifically is the one that I'll speak to because the other folks aren't on the phone. But my wife's a chronic non-operable low back and neck pain patient. And so when I would travel all around the world with you, Mike, in support of the other business, when our boats would pass in the night, myself and my wife's, she would ask the question, what's changed with me? I'm about to go see my spine surgeon, my neurologist, or whoever it is. And I'm a dumb guy. So it took 12 times before I said, wait a minute. Why is it relegated to the patient who's terrified, doesn't know what's going on, to keep track and log of things that they don't even know what might or might not be important to the physician at the end? And otherwise, we just show up at the same appointment 6 months later and do the same thing, which is the definition of insanity, and expect a different result. So those two worlds, the professional side and then the personal side coming together, hit me and said, there's got to be a solution where if we could take the physician's brain, put it on the shoulder of the patient daily and say, no, do this, don't do that. And wait, did that just happen? And we could actually figure out what was relevant to them and guide the patient. Then maybe there's a there in the end. The Netflix of things, a patient would be willing to say, you know what, I'll cancel Netflix for 6 months while I go through this episode of care and pay $10 a month to do this other thing. Like, would there be enough consumerism there? And we felt there was. So we left our comfortable jobs to go explore this and try to build something that would hopefully create a bridge for patients.
That's excellent. Yeah, that's a great story. So what was the next step? You have two co-founders, so you have a team. Everybody brings a different set of strengths. Where did you decide to go? And you want to build this virtual care platform. Like, what did you do next? You're not a software developer, I don't think. Maybe you've become one. But how did you build? How did you stand up the business and bring it to life?
That's another fascinating angle. This doesn't directly answer the question, and I will. I read this book at the time when I was in flight. It was called Originals. And it went into the background of people that have made impact in business, also in social aspects of the world. And I was fascinated by that. I've got a psychology background, so I've always been a wannabe businessman in that way. And this aspect being written by an industrial organizational psychologist, Adam Grant, was really appealing to me for whatever reason. So he profiled all the people out, and it was Martin Luther King to Bill Gates, all these different people that he profiled out to figure out what was going on. And he found common threads. And one of the ones to me that was the most fascinating was you always hear about willing to take huge risks, which is true. But anybody can take a risk if you think about it. Anybody can sidle up to a poker table and say, I'm going all in on black, or whatever it might be. I guess that's not poker. That'd be roulette, but whatever it is. Anybody can take those bets. And what I think the thing that was distinct about that was, who are the best risk mitigators? And the people that had those skill sets to be able to understand where the risks lie, try to calculate and control for those risks, were the ones that seemed to win in the end. And then he went on to describe different character qualities to do that. So those were the things that we set out to try to do, was how do you try to mitigate risk behind this? So each of us had respective different opportunities and jobs that we were still working while we were ideating and building this, trying to see if there's a market in there. We explored, exactly to your point, Mike, we didn't have the competency of tech between the three of us, tech development. So we needed to find that partner. So we went out to explore that and do all the different kind of high-level exploratory components. And then once we had those pieces together, that's when you take the real leap of faith, which if you've got a day job that's a W-2, you might actually have to work some night hours to do that and make sure that you've got the appropriate agreements in place with your contractor and all those different components to make sure that you're doing the right things. So you have to navigate that appropriately if you're going to try to take that tact. But we were able to navigate that in the right way and do the appropriate things and build something up before we leapt off into it.
It's great advice for first-time founders. If you have an idea, if you think you've got something that you can build, it's totally appropriate to just make it a side hustle first. Hi, listeners. As a medtech leader, you know how hard it is to scale up your sales team and prepare them for a successful product launch. If your reps are still digging through cumbersome shared drives and web portals, clicking through an LMS that no one uses, or relying on email newsletters to stay current, it's time for a change. Your reps, they're on the move. They need on-the-go content and a single source of truth. And that's where Convey Connect comes in. It's a mobile-first, company-branded app that gives your sales team instant access to training, sales tools, and company updates all in one place. At Convey Connect, we can have your customized, white-labeled mobile app deployed to the app stores in just a few weeks, so your sales team is resourced and aligned to win. So if you're scaling your team or prepping for a big launch, please check out conveymed.io, schedule a quick demo. We would love to show it to you. So now back to the show. Find where you think you can insert yourself into the market. You probably don't have to go as far as product market fit, but you probably need to go to the point at which there's a market, there's an opportunity here, there's a need, there's a problem that we could solve, that we can uniquely solve. And doing that, I think for someone like you guys who are in the, again, corporate world, that's okay.
Yeah.
That's how so many of these things happen. So now that after you've got your team together, you have a vision, remote monitoring, tell us what that is. Tell us about the virtual care world, and then tell us why it's important.
That's a great question. And I absolutely love this space, especially in this audience that you guys have curated, which is so wonderful in my past life in the med tech space, because it's so new. And a lot of med tech tends to be around musculoskeletal, and a lot of musculoskeletal, in my experience of almost 14 years in it, is so transactional that it's not intuitive. We've now pulled out and we've gone into some of the other ologies or medical practices like cardiology, endocrinology. It's closer to their native tongue than it is in the musculoskeletal space. And yet it's coming where today there's nice carrots and fruit for people to care about it in this field, but maybe it's too much of a distraction from their core business and there's too much fear of change that it's going to take to do. But in the near future, there's going to be sticks and other things that'll drive it and drive awareness around it. So, and I love the distinction of remote monitoring versus virtual care. At a high level, virtual care is really just anything that happens outside the four walls of the clinic with a patient or a hospital with a patient. What happens with that care coordination in between those two spaces? In the old days, I was talking with a great friend and an advisor to our business, Dr. Tony Russell, and he was describing, he's like, hey, I would do a trauma case or a total joint replacement on a patient, and I'd see Mr. and Mrs. Jones walking around in the grocery store or over at church. That was my virtual care of that patient. And I had so few of them because the reimbursement was there for me to be able to navigate that. And I could see people out in the neighborhood because care was delivered where the people were. And now there's too many people, not enough providers. And so the disconnect keeps happening. And so we want to solve that disconnect problem. And that's where I think virtual care at a high level for our business is really about providing that connection and bringing the care back to the full continuum of patient care overall. And so now you don't just say, hey, you need surgery, I'll see you in 2 months. Now it's, hey, you need surgery, we're going to put you on this perioperative optimization plan. We're getting a navigator between point A and B, and we're going to be tracking to make sure that you're headed down the right path. And those things are so intuitive and used to be a part of the old delivery model of healthcare. We're basically making what's old new again, but using tech to try to enable it.
That's great. Yeah, I'll tell you, from a standpoint that I look at this, Scott, I'll give you an example. I've got my insurance company, my health insurance company. They have telemedicine, right? And on a regular basis, it's like, instead of me having to run off to the store or run off to the clinic, I'm able to call them up literally and sit there and talk with them. And they're looking at me and my symptoms and everything else like that. And boom, it's done. And so there's extreme value to the patient in that.
That's a great point, Chris. And it's funny when people ask what it is we do and not getting into technical jargon. If you lined up 10 physicians, this is a bit controversial, but if you lined up 10 physicians and you said, do you give enough access of care for yourself and your care team to your patients? I think most would genuinely and honestly say yes. And it's because they can't work any more minutes of a day. They're already overloaded and overburdened as it is. So how could I give more access of myself to my patients? If you lined up 10 patients, of which I'm sure we are at least 3 of those, you'd say, do you have enough access to your care team and to your provider when you need it? It's about convenience. The answer would probably be resoundingly no. Right. And that's really the crux of the market that we're trying to solve, is helping providers provide the care that the patients have become to expect in a way that actually generates revenue for a practice so that it's sustainable and scalable, but also in a way that delivers care the way that they want care to be delivered, because they've fostered that trust with their patients. And a lot of that doesn't have to do with tech. It has to do with process in the process of building a service line out for these groups.
So let's just do a hypothetical. Physician practice, multi-specialty maybe, doesn't have to be musculoskeletal, is ready, has learned enough, read online, heard from their peers that they want to get into more virtual care and set up a remote monitoring program for their patients. How does that work? How do you guys come alongside and shepherd them through that process and help them get that up and running?
This is where the rubber meets the road, is with these types of things. I think if you line up the tech and the clinical staff, everybody's pretty much plus minus equivalent. It is in those processes is where success or failure happens. We believe in it so much, we trademarked specifically our process itself. We call it Hyperpath, but it's a programmatic change management, which is potentially a negative connotation of a word. If you speak it to the team or the staff, they might say, oh God, here comes another EMR change management. I'm gonna have to get a new EMR. It's not quite to that level, but it really is change management. It's building a new marketplace. And we've got processes and forms to fill out that actually make sure that we're capturing what the providers want and the care team wants, so that we're extending care the way they want care to be extended and delivered. And we're escalating what needs to be done in their workflow, which is really important. And that's a matter of a 1 hour working session with the right teams, or spread out over periods of time to get the inputs that we need. And then they could literally start within a week, because it's not a big lift. That's the nice thing about virtual versus, say, adding an imaging service line. You got to order capital, bust out walls, and get the electrical all done. This stuff is easy to scale up as long as you've got the right starting point and the right collective vision of where you want to go.
So it's really the team has to be ready to accept a new paradigm. This is what I'm hearing you say.
100%, which I would say starts at the top, which I guess it does, because someone has to agree to do it. But in healthcare today, the tail definitely still wags the dog, in the sense that you've got everyone within the office, the moment that something bad happens, because again, they're all at max capacity. If there's something out of sync and someone complains about something new, that could cause all sorts of dilemma inside the program as a whole and inside their organization as a whole. So we really take care to go top to bottom and make sure that every key stakeholder has an opinion, has their opinion heard, expresses any concerns. We try to address those concerns and then address it as a team moving forward.
So when you break it down, as you guys are taking and we'll say sharing the idea with the clinic, the operation there, okay, give us the steps and stages as to the eventual acceptance.
That's fascinating. So the first one is exactly to Mike's point. You've got the concept and agreements, then you have the onboarding stages, then you kick off. And I think that's your question, Chris, is like, after you kick off, what are the levels of traction and stickiness? Everyone does follow a very similar pattern, because these are not even that new CPT codes, but new to them. So new reimbursement that they're not quite used to. So there's an exploration of, all right, is this even real? And I think in the first roughly month, because these are 30-day CPT codes, they'll explore it, then they'll go build them. And it's typically within some contained number, whether they verbalize it or don't. They've got some number in their head that they're comfortable with, that they would apply those patients to the platform. And so as a part of that, they're getting a feel for, how do I describe this to patients in regards to a prescription or telling them this is something that they want?
Right.
So they develop that component. How do we escalate? Do the escalations really work well? And then lastly, does the reimbursement work well? So those happen at a loose level at the first month. Then the second month is expansion of payers and expansion of condition and patient types to start to explore kind of the edge cases of where they didn't think it was maybe the best use case. That probably is over a 2-month period. And after a quarter of experience, so 3 months of time of actual program implementation, usually even for the people that are later stage adopters, that's when they're convinced, because we've been through enough escalations, enough potential patient complaints, and enough volume and enough issues of EOBs coming back or not paying, and those different types of things, to where there's confidence built and trust in the program.
That's great.
I'm curious. So then there's a learning curve for the staff and all the providers. So it sounds like it's 3 months, 6 months. What would you say they ramp up and it becomes part of the regular workflow? They've built that habit and it's part of their regular sequence.
I'd say 3 to 4 months, and it's because of exactly the way that you asked it. When it becomes a part of what they do naturally, another one of the co-founders says, make it a habit, not a hobby. So once they've made it a habit, not a hobby, of what it is that they're exploring, it's typically around that time frame where all the different kinks have been worked out in regards to, how do I know that, and the patients have come back sometimes too. So now I know how to flag them and speak about it when they're in the office. Been through all the different scenarios, typically around that time. And then they've even by that time too, they start to hear the feedback from the patients, which is that's what it's all about. When the patient comes in and says, my care navigator, Anna, or whoever, man, they're like my guardian angel. We just had this happen actually the other day with a cardiology practice in Central Florida. A patient came back into the clinic with a relatively new account, brought a handwritten note and said, how do I get this to the care coordinator that you guys have put with me? Because I put my life in your hands as the cardiologist, but she really has helped ferry me from point A to B in between these visits in a way that makes me feel so much more comfortable than I did before I was a part of this. And then when they hear just one or two of those, they're like, okay, there is a there for this. And that really galvanizes it.
Healthcare, it still requires a human touch. It's not going to be completely replaced by robots and digital tools.
No.
At the end of the day, it does require one human to take care of another human. And so what I'm hearing you say is that it's the marriage of the tech and the high touch that has driven some success. Talk about the reimbursement. How does that work? And what is that the reason that groups are doing it, or is that the reason groups are not interested in doing it because of the work of the reimbursement?
Yes. It probably is across both of those ends. To talk about the reimbursement piece first, virtual care as a service line is what we call this. So just like back in the old days, I will give a more orthopedic specific example. Starting a physical therapy clinic maybe didn't exist. It wasn't commonplace inside of an orthopedic outpatient practice. So someone along the way had to say, I like what they're doing. Why don't we do that? We'll go hire someone, build out the space for it, get the equipment, and start seeing patients and billing these codes that someone else is billing and making money off of, and we'll vertically integrate that service line. It's exactly the same thing that we're doing inside this. Virtual care has a cadre of codes, and I view it as our job is to cast a meaningfully broad net where it's relevant clinically to what it is that people are doing, and we go find those things and then bring them in and bring them together and then make them make sense for people and put them into these programmatic elements. And so the big buckets under that are remote patient monitoring, which has remote physiologic and remote therapeutic monitoring as children under that bucket. Then you've got care management as the second bucket, which is chronic care management and primary care practices, principal care management and specialty care practices, and then a new one that actually just came out called advanced primary care management. That's really exciting. And then health assessments is the last bucket, which are just glorified surveys. Like many people don't know, you could do a brief behavioral assessment of a patient and get reimbursed for that, and alcohol counseling, or those different types of things get paid. So those are the three macro buckets. And what we try to do to the point of reimbursement is figure out what's clinically relevant to that provider and then layer in the ones that make the most sense as that kind of consultative partner. And then ultimately ends up being almost like a subscription basis for the physician. So it's different. It's less transactional, like I did this procedure and I got paid for it. Think more like Netflix and those types of things in regards to monthly fees. So the reimbursement structured that way. It's either per 30 days or per calendar month. There's some level of reimbursement that comes in as soon as certain levers are hit. So that's where the tech is helpful, because all those things are just black and white. You did hit it or you didn't hit it. You did or didn't hit it over this time frame. And that's where we've automated all that tech stack to make sure that it shows how they could get reimbursed, but then also does all the documentation for them in case ever audited. And they could say, here's what it is, to take away some of that fear, like you described on the second part of your question of, is that a part of the concern of what's been done or what could be done in this new reimbursement? We've gone through painstaking detail on the tech side to make sure that they're covered on that end, but it still is an area of trepidation, because even though codes might be now close to 8 to 10 years old, in some instances, it's still new to them when they're experiencing it.
Yeah, makes sense. A question that comes to mind is thinking about that point of use as it relates to the clinic type. If you think about the way we've all been trained as patients and otherwise, if you think about it, it's like, okay, I'm going to go to my GP. I'm going to start there, right? And then from there, remember when everything was the buzz about, well, insurance isn't going to pay for it unless you have a referral pathway, right? Explain, where is that base for you guys, that top down? Is it that you see the lowest hanging fruit at the general practitioner level, or is it sidestepping that and going straight to the specialist?
This one might be controversial as well, but I love the question. So we've got another orthopedic surgeon advisor that used to be at Ortho Carolina, now is at Mayo in Florida. And this is 5 years ago. He told me what used to be a holding gate for patients in the primary care space has now become a toll booth. to pass patients through straight to us because they're inundated with patient volumes too in the primary care area. So where they used to see something that was much later stage, much more ready for an intervention of some sort, now they're actually having to figure out, how do we do pain management with these patients, and how do we need an injection clinic to try to keep them in the staging pattern before they actually need the definitive intervention that happens. So I think that's an MSK example, but I think that's a general theme that's happening across all specialties. And we're seeing that in kidney disease and in cardiology and in all these different elements. They're seeing the patients faster. That's one response. The other response that I think is a really fascinating dynamic that's a little bit different than that is the hierarchy of physicians. So never bite the hand that feeds you. So that being said, despite the fact that those patients come through, if they already are on a virtual care program with a primary care physician, and let's say it's a cardiologist that's now wants to try to extend that, the cardiologist will more than likely defer to the primary care physician because that's the person that sends them new patients. They don't want to bite the hand that feeds them in regards to a referral pattern. However, if that same cardiologist has a nephrologist and they both are trying to manage the hypertension of a patient, they'll absolutely go to bat and say, this is my patient, my hypertension that I'm managing. You manage the kidneys and stay out of your swim lane. So we've seen all those different dynamics in regards to meritocracy of who's the most important at which phases. And it's not what you might intuitively think, like the specialist always wins or anything like that. There's definitely an element to that.
That is super fascinating. You're uncovering some, I would argue, inefficiencies in our current healthcare system,
no doubt,
with the lack of coordination. And it is a big problem in the United States.
As we've gotten older, all of us guys, because I want you to think about this. One of the biggest arguments that I hear from so many people on a regular basis is most doctors, because of how subspecialized everything has gotten, are not truly treating the whole patient when they show up.
No.
Is this a bridge builder, Scott, to where we get those all connected back again?
That is definitely an ideal future state. The current reimbursement structure doesn't unfortunately allow for a lot of that. And those are some of the things that we as a young business in a building marketplace are trying to sound the alarm for. As an example, like I described earlier, if a nephrologist had a patient on an RPM platform, a cardiologist couldn't have that same patient, even if they were distinct issues, end-stage renal disease, of kidney failure, and hypertension or heart failure for the patient on this end. They couldn't both bill. So that limits the type of collaboration that they could have with each other in ways. But I think to Mike's earlier point of market development, that's just hopefully something that will come with time as the market gets developed and they start to see, because they're not just going to pay everyone. They need to see the use case of where that makes sense. And I think you're spot on, Chris. That is absolutely a gap in care and needs to be better aligned with coordination. And maybe that's some of these new codes. The Advanced Primary Care Management Code I referenced is largely about coordination of care between groups. Okay. So they might be moving in that direction. And I didn't even pick up on it until you asked that question.
And I'll tell you what, because you guys figure this out and get it to where there's 2 points, 3 points. If Mrs. Jones is 70 years old and she's got 4 different points of care, right? The Holy Grail would be that they're all in sync, right? 100%. I mean, it used to be, think back. It used to be, well, I'm changing doctors or I'm going here, I'm going there. Okay, I'll fax your file over. Right?
Yep.
That's the way it was. But I think the communication breakdown, to quote Led Zeppelin, we have to. We're on the show.
That's right.
Is a major issue. And so that's why I'm just saying, as an outsider looking in at what you guys are creating, that's a Holy Grail moment.
That's a really cool thought. I was just with my brother last night for my mom's 77th birthday, and he works for Philips. He sells PACS systems for them. And he was describing the PACS system as actually more like the idea of an EMR than the EMR is. EMRs have just become notes and documentation or whatever. He's like, the PACS system is finally working its way to where if they get one image in and it shows potential cancer signs, they can flip through the list of other things in the past and go, oh, you know what? There was an early detection somewhere over here. Let me pull that note out. Or they did look at this same area 2 years ago. Did this anomaly exist or not? Which was an inspiration of electronic medical records, or at least the ideation of it was to be able to cross-pollinate those different things, but it hasn't really embodied itself in the market. So I agree with you. I think things like that and things like our solution would hopefully ultimately create that bridge. And it's happening organically, even within our own customers, which is cool to see. So in one area that we've got several different customer types, like an oncology clinic, a cardiology clinic, and a musculoskeletal orthopedic group using us. We've had some of those groups call us and say, hey, I had heart failure, I was here, but now I'm going over to see them and I want to be on it with them too. And so the physicians would actually call us that were using us and say, we've got a patient that's a patient for this group over here at the cardiovascular clinic. They're seeing us now for cancer. Can we add them as a part of this? Or a new physician wants to add the program because he's had so many patients talk about it to him at that point. And like the cardio-oncologic overlay is one of the more progressive areas inside the cardiology space. So it's natural that we're finding these areas where there are these specialties, Venn diagrams that are kind of clashing against each other. They're naturally presenting themselves even without us having to see it. And then, well, I want to see what the results were of this, and I want to see what their ongoing things are. Even if I can't bill it, I want to be able to see it. And so we're trying to create that access for them.
That's huge.
I think that's huge. The other thing that I love about remote monitoring is the longitudinal view of a patient you'll get with the data that you're collecting. Because you may collect a piece of data on Monday, April 28th, but on Tuesday, July 5th, they could be in a totally different place. And so, but you're collecting that data almost every day, probably maybe daily, maybe several times per month, dozens of times per month if you want to be reimbursed, which creates an amazing amount of data. So talk about what the potential is for the data that is being collected to both help with coordination of care, but also with just treatment and diagnosis.
I view that's such a fascinating question. I view that as the next horizon of this. I hope I can articulate this the right way. Step one is like, can you even capture the data? Because like, if you can't measure it, you can't change it, to your earlier point. And then step two is, can you make sense of that data, which are all these feedback loops of like, did this actually improve that? Did this improve that? What happened if it didn't improve? Did it change eventually? All those different little decisions that you just articulated, Mike, that might happen over the course of 2 months of time of a patient. We're starting to see those things. And then can you pick up what actually, which is in essence, if you story it out, this is the part I hope I articulate well. If you story it out, that's a doctor's life. They start out young, fresh out of fellowship or whatever graduation, and I'm a physician, see a patient, and I get my N of 1 experience and my N of 2 experience. And then I go talk to other people and get their experiences. And then I use that mental ease to make better decisions about patients. And that's exactly what we're building as a business, is that feedback loop, almost like a physician's brain, we would hope. Nice. So that then we're never going to replace anything like that from a physician standpoint, but we might be able to get more insights on medical decision support and those types of things, and or just which therapies work best in general with which different patient types. Small, hopefully brief aside, like I didn't know this because I grew up a metalhead in orthopedics, another jam session reference, metalhead.
Great job.
Shout out.
But in cardiology, I could be wrong again, but this was explained to me by a physician. When you have hypertension, it's basically a Russian roulette based on what that physician was trained on. If you get a vein opening or a fluid restricting drug, and you might have the symptomatology of either of those things, but they don't know because they don't really screen for that on the front end. So they're like, just start with this and we'll see how it goes. And so to Mike's point, if you then tracked that patient over time and saw if it did improve or didn't improve, if that mechanism of action was the right one or not, you could more wisely adjust. But right now, they're just going on their gestalt or their mental ease about what their experience has been and said, well, that didn't work. So my experience tells me do more of that drug or add this to that drug and see if that changes. So we could maybe, that's an example or a use case of how we might be able to help treatment options as well over time.
So forward thinking, and this is a big question. It could be a loaded question. I don't know how far this is going to take you, but forward thinking, you're becoming a data king. Okay. And as I think about this, can you get to a point, do you see this on the horizon to where enough patient data can become predictive?
100%. It can. We saw it because we had really bright engineers that we worked with, Mike and I, in our past life, where we had that dilemma, and with probably less data than we're capturing, it became pretty highly predictive, even on implant design. Change this, what's going to be the outcome of tissue strain? Change this, what will the rollback be volumetrically, and then what that might do to the soft tissue capsule? I think we're now just amassing those same types of data, even without AI. AI is great, but simple things like regression equations and sensitivity analyses, those are predictive in nature too, to at least tell you, watch out, when something looks and smells like this, you typically see this result. And so when you change it and do this, you might see this result, which is a better result. So I think there's even steps to be made before you throw AI at it in the grand scheme of things. But, and I only mention that because I think FDA and other groups are trying to figure out how to handle AI. And so I think it's going to take the regulators a long time to catch up of how to maximize and apply those things. So I think there's meaningful market steps in between point A and point D that could do what you just alluded to.
Yeah, that's big.
I think it's big too. I think, but the missing step has been collecting the data longitudinally over a function of time.
Exactly.
Smaller increments of time than, hey, every 6 months I'm going to take your blood pressure. No, I'm taking your blood pressure every day for 6 months. And you'll see the fluctuations that happen. Maybe you're capturing their weight. Are they gaining or losing weight? Other symptoms? What is their activity level? Is it holding steady? Are they getting more active? Are they getting less active? All those things combined together as a function of time, I think will teach us something that we don't yet know about the therapies that physicians are prescribing for us as aging adults.
And the cool part to react to that about it is all that stuff might even seem overwhelming for a provider, a surgeon, a physician, because they're like, I can't stand any more data. And I think that's to your point earlier, Mike, of where the human piece fits back in again is in the importance of the change management is we're trying to get a glimpse into your brain of decision making and put that on a piece of paper so that you don't have to do it. We can look at that stuff and we can manage it for you. And then you only hear we'll manage the signal to noise. You only hear about the things that are actually relevant to you or to whatever scope of practice exists in your business. If the MA can handle it, then the MA is going to be the person that gets the message quickly about it. And it's going to be so few and far between because those are the minority alerts that happen or escalations that happen. But then in the background, to your point, we're amassing all the data along the way about why it's just as important to know what went well as it is to know what didn't go quite as well, because you want to repeat what went well a lot more.
Yeah, exactly.
Well, and you want to catch what's not going well quicker so that you can mitigate it.
That's a great point.
Yeah. Well, Scott, this has been great. We are up against time here. Where can our listeners go to learn more about MiCare Path?
Our website, which is a funny spelling, but MiCarePath.com, MICARE. And then our LinkedIn is a great place just to keep up with any of the changes that are happening in the market. We try to be, because this is a new market, and especially for the market that we hold dear to heart in the musculoskeletal space, it's very new. We try to be somewhat informative in some of these things and let people know when codes are changing, when it becomes more applicable. And I do think in that space of ortho and musculoskeletal, I mentioned the carrot and the stick. Carrot's the reimbursement piece, obviously, but the stick is coming soon. The CMS has TEAM, which is the bundle payment, and it's going to be mandatory for specific hospital systems. And so why not get the benefit of guiding your patient without having to use your staff to do it, leveraging these virtual tools to be able to get it done? That time is going to come where there's enough pain to where the change doesn't feel like it's change pain.
Exactly.
It feels like it's a necessary element. And I think that's on the near horizon. And we've been figuring it out in the other markets of cardiology and endocrinology well enough to be able to now institute it efficiently in some of these other spaces.
Well, and I think what you just said is so important. Institute it efficiently, because again, when the stick comes, what's going to be normal behavior for physician groups to be like, we got to go do this right now. And so you've got a process that you can slide in quickly, efficiently, and not only solve their problem, but provide great service to patients, a new service line for physician offices, and collect all that great data for future innovations.
Absolutely.
Awesome, Scott.
Good
Man, we're
stuff.
super proud of what you built, and thanks again. You crushed it out. You crushed it on the jam session, as we knew you would.
Thank you guys so much for the opportunity. This was fun.
Yeah.
Yeah. There can always be follow-ons, and believe me, it's one of those things to where it's like, look, we live in this world of reality TV, and this is that, right? And being able to come back around in a year and go, so tell us what shifted.
Yeah, for
This
sure.
is why Mike and I'll be sitting here and we'll be doing this when we're 80, because there's no reason to stop.
It's so true. And so much does change in a year. It's crazy. But perceivably as negative as like these pivots that companies do are sometimes necessary.